The OrthoPAC podcast, hosted by Sam Dyer, Chuck Dowell, and Miles Gilbreth. Welcome to the OrthoPAC podcast, where we attempt to fill in the gaps between education, current events, and real-world practice. Welcome back, listeners. Today we have another panel discussion with Chuck and Miles, and we're talking about when can we return to sports. Guys, what have we missed? We're talking today about returning to sports and can you work through an injury? We talked about some different conditions. Any other points that we want to share with our listeners?
Well, I'd say one of the things I thought about when we discussed this topic, I have a good friend at the same gym I'm at, and I've treated her a couple of times from some aches and pain injuries, and she has kind of some known cartilage wear. And she saw one of the surgeons at my practice, and he kind of said, "Hey, you have some early arthritic changes. Don't run anymore." And she's like, "I love running. I miss running. Like, what should I do?" And I think that's a very controversial topic, and I'm kind of curious of what your guys' opinion is on this, because we get family, friends, we get a lot of patients that come in and they've seen somebody and they say, hey, maybe they have grade 1, grade 2 changes, some early arthritic changes. And the answer is always, let's completely avoid impact sports activities as not to make things worse. And I think the literature is a bit mixed, maybe slash saying, hey, maybe these activities are okay. So what are your guys' thoughts on that situation?
I mean, I think it definitely has to be individualized to the patient, right? So if for her specifically, right, if the way I would approach it is if every time she runs, her knee hurts, then maybe we should consider that that's not a great sport for her long term. If her knee doesn't really hurt after she runs, it's really other things that are aggravating it. I wouldn't personally, I wouldn't lean towards taking something that someone loves away from them just because they have some degenerative changes present on the Xray. And I agree. I've seen articles and research that go both ways on that. And so I think it just being a mixed bag topic is you have to weigh each individual patient, what's hurting their knee, and then really what they love. If you take away something someone loves just to reduce some knee pain, I mean, they're not going to like that. They're not going to be happy. They're not going to be a mentally healthy patient.
So my experience with that would be, first of all, let's make sure that I'm comparing apples and apples. What did the person say? I'd like to see their studies and their notes and that sort of thing. But if I'm just giving somebody off the cuff advice, I would say, moderation is the key to life. And if you can run some, but substitute some cross training, like maybe an elliptical machine, maybe swimming, maybe water jogging. If you do have arthritis, I've seen a lot of people with, advanced arthritis who are runners that, it's like just miserable because they can't. Well, how about water jogging, or how about some water aerobics? Now, granted, that's not the same as running, like I said earlier. If you tell a runner they can't run, give me your birthday, give me your firstborn child. That's been my experience. But if you can do things in moderation, why don't we try that? Why don't we try some physical therapy to strengthen some of those collateral structures, the structures that are supporting the knee to take some pressure off? Why don't we discuss weight loss if that's an issue, because that can be something that causes increased pain? Why don't we discuss periodic use of NSAIDs, where you can maybe pre-medicate yourself before you go? What about, the gel injections? There are a lot of options. I mean, it doesn't always have to be all or none. But that being said, you also have to say, well, if Dr. whoever said that, you shouldn't run, they are thinking that your arthritis is there. It might get worse, or it could cause you more symptoms. You could wind up needing surgery. So all of those things play into it. So how important it is for you to be able to do these activities. And I think it's very important to kind of, come up with a plan. Why don't we do this? Why don't we try this? And, with the knowledge that it could get aggravated. Well, if it does, we have some backups. And that's kind of how I would go with that.
Yeah, I think that's excellent. That's kind of the advice I gave her, and that's kind of my thought process. As Miles said, I think the literature is pretty mixed, but I think there is some new, pretty good literature coming out that shows that, impact loading activities doesn't necessarily and or significantly progress arthritis, but it's individualized based upon BMI and muscle control and things like that. And as you said, Sam, I think it's important to understand that if you can improve your dynamic stabilizers, the muscles and the soft tissue throughout the area, it could potentially reduce the progression of things or the impact loading on that joint. And so that's the number one thing I recommended, is that she kind of does an exercise program. And then number two, as Miles said, I recommended that, in moderation, I think it's okay to run maybe once a week or twice a week. But I also think it's important, if you haven't run in a long period of time, to gradually ease back into that, because your knee's going to need some accommodation. Your cartilage is going to need, your body's going to need some accommodation to get back to those impact loading activities. And so you can't go back to running 3 miles a day right away. You have to run half a mile, 1 mile, let your body accommodate to it over a week or so period, and then progress up from there, because otherwise that aggravation from getting back to that impact loading activity will be much more substantial. And then, as you said, Sam, I think, the modifications into injections and anti-inflammatory medications can always be helpful. But I just think it's important to, as you guys have mentioned, not take these activities that these people love to do away from them, because there's definitely a psychological component to it. If you can encourage them and allow them to progress back to a lot of those activities, they'll be very happy athletes, very happy patients, as long as you can kind of do it in a controlled, modified fashion, which I think is important to talk to patients about.
I think it's very important. I mean, the science is important and all the other things are important. But my mentor taught me this early on, and I think it's a critical lesson that our younger colleagues need to know. Give your patient hope.
Hmm.
There's always something that we can do. At some point, there's nothing you can do and you got to do surgery, whatever. But always try to give somebody hope. That's why you're there. That's why they're seeing you. I want to get better. Let's focus on their life. Let's talk about what's impacting them. The knee is like the clinical part, but what can I do to make you better and how can I help you? And let's get some hope in there. I think we can help you. I think I'm going to help you to get better. And those kinds of things carry a lot of weight in my experience. So don't forget, it's not always gloom and doom. And if somebody says, well, you're never going to run again, that's not great. So, I just think that it's important to relay that to your patients. But that's kind of how I think. So
I always, especially for like a runner that might not be able to run for a certain period of time, I always try and offer an alternative forward moving exercise, whether it's being on the bicycle, an actual bicycle, not a stationary bicycle, or just a simple walk. Because I think there's been good research on the psychological benefits of forward moving exercises that move us forward in space. And they kind of create a good mental state that allows us to move forward. It's kind of what we're designed to do as a species, is move forward. And so that's definitely a conversation that I have a lot of times with people.
Yeah, I think that's a great point. And I think as providers in orthopedics, or just in general, with all the stuff we've talked about regarding injuries and athletes with injuries and when they can participate back into sports, I think the psychological component is more than 50% of their ability to get back to activities. And like you said, Sam, giving them hope, or giving them a timeline and saying, hey, you can recover from this, you can heal from this, you can get back to play sports from this. We may have to take a short period of time off, but it's a short-term loss for a long-term gain. And our whole goal is to get you back to be able to play these sports. This isn't season ending, and it could be, but this potentially isn't season ending or career ending, or we're not going to eliminate these activities, for the rest of your life. And I think we have to think about the psychological component to all of these discussions with these patients, because that's important to them. And these, sports or activities are very important to them. And us showing that we care, showing some empathy, showing that we want to get them back to these activities, but we're going to do it under the most controlled environment possible, is kind of important to educate or discuss with them.
absolutely. And I'll jump forward a little bit with that. I got to get back to sports. I've got this game or whatever. One thinking would be, well, we need to sit on it for a while, do whatever. That's not how sports medicine folks think. Sports medicine that's as important to me as it is to you. Let's go get the MRI and let's get your knee scope done before we do all this other stuff so you can begin your rehab and get back to it. So, think along those lines too. It's individualized to the patient. I think somebody said that earlier. Guys, I don't want to have the last word, but I'll have the last word because I know Chuck has got to go to the OR and Miles has got to go to work, and I'm going to hit golf balls. So before it becomes frigid here. So I appreciate you guys coming on. I love this panel discussion. I hope that our listeners find this beneficial, and I hope they enjoy it as much as we do. And we'll be back soon to talk more orthopedics. Listeners, I hope you can join us at one of our upcoming CME meetings. We have our musculoskeletal ultrasound workshop from February the 28th through March the 2nd in Charlotte this year. We also have our Ortho in the West annual conference, March 28th through March 30th. Look on PAOS.org for details.